Hello, it's Dr. Garrett Pohlman, host of the Prostate Health Podcast. Joining us today on the podcast is urologist Dr. Will Parker from the University of Kansas Medical Center. We'll be discussing everything you need to know regarding the various different approaches to prostate removal for men with prostate cancer, so stick around. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast. The Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I'm very excited to have on as our guest today Dr. Will Parker. He is certainly an expert when it comes to prostate cancer. His training included a Urologic Oncology fellowship at the Mayo Clinic in Rochester, Minnesota. He is currently a practicing urologist at the University of Kansas Health System and an assistant professor at the University of Kansas Medical Center. He is helping lead the way for fellow urologists and trainees in managing prostate cancer, as well as evaluating innovative new techniques for surgery in men with prostate cancer with the goal of optimizing their quality of life. Dr. Parker, welcome to the Prostate Health Podcast.
Thanks for having me.
So Dr. Parker, can you tell our listeners a bit about what is a prostatectomy?
Yeah, so at its heart, a prostatectomy for cancer is removal of the prostate gland in order to provide some degree of either cancer control or cancer cure.
And how long has the prostatectomy been around for?
So prostatectomy has been around for quite a long time. The first one was described in the early 1900s, so it's been around for over 100 years. And the first procedure was actually done at Johns Hopkins in 1904, so quite a long history with prostatectomy.
For sure. Now, what are some of the potential consequences of removing the prostate?
Yeah. So, I really, when I approach the man with prostate cancer, there are kind of two parts to the counseling. There are the surgical risk, but then there are the quality of life impacts, which are really more side effects as opposed to risks. And those are going to be things like incontinence and erectile dysfunction. And so incontinence here would be the leakage of any urine, but particularly with activity. And then erectile dysfunction being the loss of, functional erections as a result of the surgery.
So then what are some of the other risks men need to be aware of when being counseled regarding the option of prostatectomy for prostate cancer?
Yeah, absolutely. So, risks. So obviously, as I mentioned, so side effects are things that I expect as a consequence of removing the prostate. The risks are more things that just come with doing an operation like bleeding, infection, because removal of the prostate requires us to really disassemble the urinary tract. There's risks of leakage of urine from where we're putting things back together again. Stricture formation is really scar tissue where we're doing all this kind of complicated reconstruction. And then injury to things that live generally in the area like the rectum, blood vessels, nerves. Thankfully, those are all very rare risks, but they do happen.
So I have a lot of patients I see for various other prostate conditions, such as prostatitis and BPH, come out and ask me, so can't we just go ahead and remove the prostate? What's wrong with that?
There's a saying, just because we can doesn't mean we should. So, I personally would never advocate removal of a prostate for a non-cancerous reason, just because these impacts, particularly the sexual dysfunction and the urinary dysfunction, are pretty severe, at least at first. And so it's a big price to pay for a non-cancer reason.
Certainly. And kind of when I have those discussions too, they certainly, patients will back off and, I want to keep my prostate for now. So over the years, there have been really various different methods employed to remove the prostate. Can you tell our listeners, first of all, about some of the more traditional approaches to prostatectomy?
Certainly. So, when we think traditional prostatectomy, we're really talking about open surgery, so surgery with our hands. The initial description was actually done with what we call a perineal prostatectomy. So that's in the space in between the scrotum and the anus. And we would make an incision in the skin and actually approach the prostate from between the legs. Thankfully, that's fallen by the wayside because it's a very complicated way to approach the prostate. And the more common traditional method would be to make an incision or a cut in the skin in between the belly button and the pubic bone and remove the prostate through that opening.
Sure. So now moving on to what both you and I perform, the robotic assisted laparoscopic prostatectomy. Now at the University of Kansas, you've been quite active in evaluating some of the new innovative techniques for robotic surgery. But first of all, can you tell our listeners about, what is a robot and why do we use it for prostate surgery?
Absolutely. So first off, I think it's important to note that robot is a bit of an interesting turn of phrase because what we actually use isn't a robot. I think a lot of people get this concept in their mind about a robot because a robot is an autonomous unit. We program it to do something without any oversight, which is not what this is. So it's not like I hit autopilot and the prostate's gone. This is really a tool that we use that allows us to mimic motions with our hands in more of a refined and smaller scale so that we can get access to this really, really actually anatomically small area in the body in order to do pretty complicated surgery.
Sure. And it's funny you mentioned that because I've had some patients that had their surgery done elsewhere and I asked, well, who did your surgery? And they told me Da Vinci. And I said, no, who is the surgeon? And I think some people they were convinced that it was the robot that did all the surgery, but there actually is a surgeon behind, operating those instruments and not just the robot itself. So,
yeah.
So next, let's talk a little bit more about the traditional robotic approach, the transperitoneal prostatectomy. So what does that mean and what can patients expect in terms of, where the incisions are made and so forth?
Yeah. So, a transperitoneal prostatectomy, which is really when you think of prostatectomy as a whole across the United States, probably 95% of all prostatectomies are done in this way. That involves generally 5 to 6 small incisions that are made at about the level of the belly button or above. And through these small incisions, we introduce instruments into the peritoneal cavity, which is the space inside our belly where our intestines live and our organs live. And then from that space and filling up the belly with gas, we're able to get access to where the prostate actually lives and remove it.
And typically, how long are patients in the hospital after that procedure?
So thankfully, it's only about an overnight stay in the hospital for most men, unless there's some sort of a complication.
And typically for your patients, how long will they have a catheter indwelling draining to a bag before they can get that out?
So I leave the catheter in for anywhere from 1 to 2 weeks. And the length of the time with the catheter really depends on how much work it takes for me to put the bladder and the urethra back together again.
Certainly. And a lot of patients ask, or when can I go back to work? And as far as lifting restrictions and so forth.
I tell most men 10 to 15 pound lifting restriction for 6 weeks. Now, it's not that we're operating on their arms or legs. It's because these small incision sites are sites for potential hernia formation. And that first 6 weeks is really the key period of time for wound healing to keep a hernia from happening.
And I know this is variable from patient to patient, but in terms of, a lot of patients will want to know, well, how long will it take me to get this urinary control back? And I know that's changing with some of the newer techniques, but just in terms of the most common method, the transperitoneal method, as far as regaining that urinary control.
So it's a evolving control. What I tell most men to expect is at first they're going to leak a lot, enough where they might require a depend or multiple depends in a day. So adult diapers, essentially. Where gradually and pretty quickly within the first week or two, you'll get down to pads. But most men, it's going to take on average 6 months before they're socially continent. So no pads per day, walking around, normal activities, not leaking.
So we had initially talked about the more traditional approaches, and you may be able to comment on this as well. But, I was fortunate in my training at the University of Colorado to be exposed to various approaches to prostatectomy, not only robotic, but also, the retropubic and perineal prostatectomy with Dr. Crawford. And as Dr. Crawford, but also, Dr. Moll from Duke would tell you, today's, radical retropubic prostatectomy is not your dad's prostatectomy in terms of how these procedures were performed. And, some of the surgeons that are still doing it through the retropubic approach are still doing it through kind of much smaller open incisions. And a lot of these guys still are being discharged home, sometimes the very next day, much like the guys undergoing the robotic surgery. But again, I perform all of my prostatectomies currently robotically. I've never had to convert to an open approach, but that's always, something that, I guess counseling patients that's always a possibility. But, with the training, I still feel like I would be comfortable doing so if I had to. How about, is it something that you talk to patients about or have had to convert to more of an open approach from a robotic approach?
So thankfully, I've only had to convert one time from a robotic approach to an open approach, but I do talk to men about that. I mean, I think we'll talk a bit more about the functional outcomes of the surgery, I'm sure, as we kind of go through this. But, really at its heart, this is a cancer operation. And the goal at the end of the day is to go from having a prostate to not having a prostate. So, really, I tell everybody we're going to do as much as we can to do this robotically. But if we have to, and we'll make an incision and take it out the standard way.
Definitely some very valuable information so far for our listeners. We're going to pause for just one moment, then we'll be right back to get into some of the newer robotic techniques being looked at. Thanks again for joining us today on the Prostate Health Podcast. If you're enjoying the show today, make sure you visit my podcast website at www.prostatehealthpodcast.com. There you can find show notes to all our episodes. You can also click on our resources tab, where you can find links to our trusted partners of the podcast, as well as links to books, resources, and products, all of which can help in your journey with either an enlarged prostate or prostate cancer. You can also sign up to receive my free What to Expect guide, which includes checklists of what you need to bring and how to prepare, including what to expect with 3 different scenarios, including your initial urology clinic appointment, a prostate biopsy, or prostate cancer consultation. Sign up for the free guide on the homepage of www.prostatehealthpodcast.com or access this guide directly at www.prostatehealthpodcast.com/clinic. Now, again, you've been very kind of proactive in some of the more newer innovative techniques in terms of robotic prostatectomy. I was going to see if we could talk a little bit about some of those different techniques in terms of, which ones are available and maybe what sort of advantages each one has, and how is that different from the more traditional robotic approach, starting with the Retsea-sparing prostatectomy.
Yeah, so, the Retsea-sparing prostatectomy is one of the newer ways of removing a prostate. The space of Retzius is really a potential space that exists in between the bladder and the abdominal wall. I think a lot of people aren't familiar with the idea that the bladder and the prostate really don't live inside of the abdomen. They live in front of the abdomen. So there's outside of where the intestines are. And to gain access to them, we have to do things to get into that space. And in a traditional prostatectomy, we approach the prostate by taking the bladder and moving it out of the way, moving it into the belly. And that distorts some important support structures that keep the pelvis in its normal anatomic position. And so Retsea-sparing prostatectomy involves approaching the prostate from underneath the bladder, in between the bladder and the rectum, and removing it through a pretty narrow opening. The advantage is that we leave all those support structures intact, and so there's a much earlier return of urinary control. On average, it takes 1 week for most men to restore their continence. And in fact, 1 out of 5 men are dry the day their catheter is removed. And so that's a very big advantage. The disadvantage is it's a very complicated operation. It's a steep learning curve. It's different anatomy than we were ever used to when we started training how to do prostatectomy. So it's a tough operation to kind of conceptualize. And the other downside is, and we know this from really good data, is that it is truly an anatomy preserving approach. We're leaving tissue in place. And the more tissue we leave in place, the greater the potential is that we could leave microscopic disease behind. Again, this is a cancer operation first. And so we are in some ways leaning a little bit away from oncologic control or cancer control in order to try to promote earlier return of urinary function.
Well, certainly a lot of men or listeners are definitely excited about some of the newer approaches. Obviously, a little bit more of a learning curve, but to try to make these improvements to get that urinary control back quicker is certainly exciting for the field. Now, in terms of some of the other techniques, one of the ones, the robotic extraperitoneal prostatectomy, can you tell our viewers a little bit about that and how it differs?
Absolutely. So the extraperitoneal prostatectomy is very similar to the transperitoneal prostatectomy, except we don't begin inside the abdomen and then work our way towards the prostate. We create that space in between the layers of the abdominal wall in order to remove the prostate. And the advantage is we don't ever approach the intestine. So all of the intestinal complications that come about from this surgery, which again, thankfully are rare, are almost non-existent. So severe constipation leading to readmission to the hospital and hernias into the groin are almost unheard of with this approach. If there was ever going to be a way to do an outpatient prostatectomy, this is probably the only way it would ever happen. Now, the downside is that it is very hard to access the pelvic lymph nodes and remove those from a cancer standpoint. So for men who have more aggressive disease, this may not be an adequate approach.
Certainly. And then lastly, the robotic perineal prostatectomy.
Yeah, the robotic perineal prostatectomy is one of the newer things on the horizon. The company that makes the robot recently came out with a newer version, which is what we call a single port robot. So all of the instruments that we use go through one single incision, which has allowed certain people to gain access to the prostate through the perineum because that's such a tight window. Now, again, it has similar downsides to the extraperitoneal prostatectomy, and that's very hard to gain access to the lymph nodes. The anatomy is very different than what we're traditionally taught. And so I imagine, not having done one myself, that there's a bit of a learning curve there as well.
Certainly. Now, we kind of touched a little bit about in terms of the urine recovery. What do you kind of counsel patients in terms of the percentage of individuals that will kind of regain that urinary control and by what point and so forth?
Absolutely. So again, it's going to depend somewhat on what approach we use. So, if it's a Retzius-sparing prostatectomy, I'm going to counsel them maybe a little bit sooner than if it's a traditional, transperitoneal prostatectomy. But by and large, and we know this from pretty big data, 95% of men are going to regain their urinary control within a year of surgery. Now, there are risk factors. So advancing age is a risk factor. Men who carry a lot of abdominal weight, because the type of incontinence they experience is what we call stress incontinence or activity incontinence. Men who carry weight are more likely to have that leakage. And men with diabetes, because the nerves that help control that urinary function may not function as well for them as if they didn't have this diabetes.
So now, in addition to urinary control, one of the big quality of life questions from men is, will my sexual function be affected? So from a surgical standpoint, kind of what options do men have in terms of trying to preserve their sexual function?
So yeah, sexual function is a huge impact with this surgery, no matter how we do it. Now, as you mentioned, there are options. So we can do a nerve-sparing prostatectomy and try to peel the nerves that control erections off of the prostate. But that's legitimately what we're doing. We're peeling these nerve tissues off of the prostate, and the nerves are actually invested in the blood supply to the prostate. So they really get fairly significantly bruised or kind of dinged up in the process of trying to peel them off when it's safe to do so from a cancer standpoint. And so even with sparing that nerve tissue, there's going to be an impact in some way.
Now, could you tell our listeners how the decision is made in terms of offering nerve sparing versus doing a wide dissection?
Yeah, I'll tell you, this is one of the more difficult parts of the discussion with prostate cancer. And really the way I frame it when I talk to men is that prostatectomy is really a pendulum between maximal cancer control and maximal quality of life. And so anything that we do that swings one way, so if I'm trying to maximize quality of life, I am inherently going to do something that goes a little bit against the cancer control and to the other extreme as we swing towards cancer control. And so what I will do for men who are, approaching this, who have normal sexual function at baseline, who want to try to preserve that, is look at the grade of their cancer, look at the amount of cancer they had on their biopsy, look at their MRI if they've had one, and try to counsel them about the bulk of the disease in the areas I'd be concerned about, and provide them some sense of what that risk might be. Thankfully, there are newer calculators and tools that are available that we can use to help quantify that risk and help a man understand what's that potential for leaving microscopic disease behind. But it's not an easy decision. And I certainly have some guys who, really, this is the sticking point. I have to save my nerves. I understand that there's a risk. And if they really and truly understand that there's a risk of leaving some microscopic disease behind, it's the patient's decision in the end. And I respect that.
And so a lot of men will then want to know, well, what are my chances or what's the success rates for nerve sparing? And I know this is a moving number as well, but kind of how do you counsel your patients in terms of that number or that success rate?
Absolutely. So, I look at the data, right? I mean, it's hard because there's so many variables that go into this. And I try to tell men this. So, at its heart, erections aren't as simple as nerves. There's libido, there are the nerves, but then there are also blood vessels. So you have to have an intact, vascular supply of the penis. And there are a lot of men who can compensate for a couple of small things being off, that then the moment you save the nerves, just because they're bruised, that's it. That's the straw that breaks the camel's back. And so what I tell guys is, best case scenario, if you have normal sexual function going in, I save every ounce of nerve tissue there is. I give them a big high five at the end of it and tell them it's the best surgery I've ever done. There's a 15% chance they'll never gain their sexual function back, and an 85% chance they will, but half of those men are going to need medications, Viagra, Cialis, Levitra, things like that, to try to help support their erections.
And then in terms of the recovery, we talked about some of the recovery times for the urinary control. I know the sexual function can take a little bit longer sometimes. And kind of what do you kind of tell men as far as potentially, how long it might take to see some of that function come back?
Yeah, so I tell them to expect it's going to be 6 to 9 months before you begin to see sexual function recovery. Not that you're going to be recovered at 6 to 9 months, but beginning. And we measure outcomes at 85% recovery is at 2 years. So it's a very protracted or long course to go from surgery to recovery. But at the same time, men who are lagging behind a little bit and their sexual function's not coming along, hope's not lost. This recovery takes a long time, and I've seen men recover a year and a half out from surgery when, really they were starting to give up on the sexual function piece.
Certainly. And do you have a certain protocol that you like to use in terms of kind of rehabilitation or trying to help out in speeding up that recovery?
Yeah, absolutely. So, penile rehabilitation is something that we've looked at as a profession often, and unfortunately have not really found the magic bullet as far as penile rehabilitation is concerned. I recommend most men try to get a vacuum erection device. There's good data that penile length can be preserved by use of a vacuum erection device. And that's just because we're bringing in good blood flow and supporting that tissue during the recovery. Beyond that, I'll have them use, Viagra, Cialis, what have, on demand. So when they want to have an erection, I'll let them, I'll tell them to use it. But outside of that, I don't use a daily, oral medication regimen or anything like that, because unfortunately, the data in terms of randomized trials have all fallen short.
Now, lastly, we've discussed all of these different options. Now, how does a patient choose which approach is best for them?
So, I'll tell you, I wish I had a great answer. The only disease I treat is prostate cancer, and I still find this to be the absolute most difficult medical decision to guide somebody through. The first thing that I really think that anybody who's going through this has to do is they need to make a priority list. And so, there are 3 things that we talk about most often in this conversation, which is cancer control, sexual function, and urinary function. And you really need to prioritize which of those things are most important and how much of a sticking point are they? What's the hard line in the sand that if you experienced X outcome, you would be miserable? And then once you have that idea in mind, it's easier to build a framework about this is what we're going to try to do, or this is what we can try to do to optimize or give that man that, experience.
Certainly. So in summary, there are various different approaches to consider with the radical prostatectomy and several factors that may go into deciding on which approach is most appropriate for that individual. Dr. Parker, any thoughts or maybe even tips for our listeners considering a prostatectomy for their prostate cancer?
Yeah, I think the most important thing is to be informed. These are difficult decisions. You've got to feel good about the information you're getting. So I think you've got to do your homework and really feel comfortable with what you understand and make sure that that is what's going to lead you to a decision. This is a really exciting time. We've made some real true advances in the surgical management of this disease. Outcomes are getting better. And so I think they're going to keep getting better.
Well, Dr. Parker, we really enjoyed having you join us today on the Prostate Health Podcast. I appreciate you taking time out of your busy schedule to visit with us, and you've really given our listeners a lot of useful information. Thank you again today.
Thanks.
I want to thank you again for joining me here at the Prostate Health Podcast. Subscribe to the show on iTunes, Google Play, Spotify, or wherever you listen to podcasts. And please share it with a friend who may find this podcast helpful. We'll see you at the next episode.